So, thanks Eleanor, and thank you for coming. My talk today is about this action I am sure you're all familiar with. Everybody takes drugs. I do. And there are many reasons for taking drugs. In my case, allergy. But the question is, do we really know what happens when I take one of those pills? Before starting my PhD, I thought that the answer was yes. I mean, at least doctors that prescribe drugs or people that develop drugs should know. Today, I'll try to convince you that the answer is no. We don't fully understand what drugs do in our body. But don't panic. You can continue taking drugs. I will, because they work for me. But I hope you understand by the end of this talk how important it is that we characterize all the actions that drugs are doing in our body in order to better use the drugs we have and develop better drugs for the future. So let's start. How are drugs supposed to work? To answer those questions, we have to talk about Paul Ehrlich, the Nobel Prize that discovered that drugs exert their therapeutic action by directly binding biomolecules in our body. So it's a physical interaction, and the drug binds the biomolecule. And here you have the structure of loratadine. This is the drug I take every morning, and the histamine H1 receptor. So loratadine binds the histamine H1 receptor in order to prevent the binding of histamine and the unpleasant effects of allergy. A very important point on this theory is that this binding should be specific. So loratadine should only bind the histamine H1 receptor. We have also to thank Paul Ehrlich because it was him who provided us with this very beautiful metaphor, and he said that drugs were magic bullets, targeting specifically one only biomolecule. So if you let me continue with this metaphor here, if this room was a cell and you were biomolecules, the drug in here would selectively inhibit one of you. Thanks a bit for dying. But the thing is, now that we are living in an era where reductionism is a little bit criticized and we are embracing more systems or holistic approaches, do you think that it's all that simple? I'll try to convince you that it is not by walking you through the case I've been studying during my PhD. During my PhD, I've been studying this protein here in green. It's called polyadditive ribose polymerase 1, or PARP1. And it's very famous because a drug targeting this protein, here in yellow, called olaparib, was found to selectively kill cancer cells without harnessing healthy ones. And these are the kinds of things you want to see in cancer, just killing cancer cells without touching healthy ones. So this was a very initial clinical trial and was a breakthrough in cancer therapy. And when such breakthroughs happen, all pharma companies want to have their PARP inhibitor in the clinics. So the situation now is that we have 3 PARP inhibitors in late-stage clinical trials. Rucaparib, olaparib, and veliparib, all supposed to be doing the same, just binding PARP1. But here is where the interesting things comes, because in the last 2 years, 3 publications have pointed out that those 3 drugs do different things in cells. So how come they can do different things if they are just binding to PARP1, all the same way? That's where we get in. At the Systems Pharmacology Lab, what we do is develop computational software to be able to predict, given a certain drug or small molecule, to which target or targets it might bind. So we applied our software to the 3 drugs I was just telling you about. Olaparib, veliparib, and rucaparib, all supposed to be the same, binding to PARP1. But we also predicted that those drugs might also bind to other biomolecules that belong to the kinase family, but it has nothing to do with PARP1. So we next went to the lab, and what do you expect to happen? Of course, you're very smart and you know that they bind. But the beautiful thing here is that they bind differently. So 3 drugs in clinical trials, people taking them, believing they are doing the same, and they are not. Olaparib is just binding PARP1, while veliparib is binding also 2 kinases, and rucaparib at least 6. So now I ask you, if you were an oncologist, which one would you give to your patient? The nice thing here is that kinases, or some kinases at least, are also involved in subtypes of cancer. So what we believe is that you could use one drug or the other depending on the kind of cancer that the patient has, and therefore personally using those drugs. But more importantly, this is just part of a growing body of evidence that suggests that drugs do not bind only to one target, but to many. And therefore, Ehrlich's metaphor that drugs were magic bullets is no longer valid. And you have a lot of bullets hitting a lot of targets. And that is bad news for you guys, because more of you will have to die. So, in conclusion, I think this picture here beautifully summarizes what I'll try to tell you today. And it's that we are effectively shooting targets, but we are doing much more things. And as you can see, there are more bullets here, and many get lost into the forest. I hope you now understand how important it is that we characterize and understand all those actions of drugs, where are those bullets doing, in order to better use the drugs we have and develop better drugs for the future. Let me finish by thanking my group, especially my PhD thesis supervisor, and you for listening. Good hunting.